Dr. Tania will be presenting levator plication versus silicone frontalis sling in severe ptosis with poor levator function.
Good morning, everyone. My topic for today's presentation is levator plication versus silicone frontalis sling in severe ptosis with poor levator function. Ptosis is drooping of the upper eyelid, which can be congenital or acquired. Severe ptosis is usually operated in the following way. Number 1, frontalis sling with fascia lata autologous homogeneous fresh or bank sclera. Frontalis sling with artificial material like silicone rod, Mercedin mesh. And the third one is maximum levator plication or resection. Our study is to evaluate the function and the cosmetic correction, recurrence, complication in both the procedure of levator plication and frontalis sling with silicone rod. It is a prospective comparative interventional case series of 40 eyes, 25 were male and 15 were female. Group A of 20 eyes were operated with levator plication, and Group B of 20 eyes was operated with tarsofrontalis sling with silicone rod. We included patients of 5 to 45 years with no sex predilection, patients with congenital ptosis, severe ptosis, poor levator function, neurogenic ptosis, BPS syndrome, and patients with good positive Bell's phenomenon. We excluded patients of vertical squint, negative or poor Bell's phenomenon, Marcus-Gunn jaw winking phenomenon, mild to moderate ptosis, and corneal anesthesia and nystagmus. Out of the 40 cases, Group A undergone levator plication and Group B undergone tarsofrontalis sling with silicone rod. In the result, we can see that comparison between the Group A and Group B result shows that there was a group uplift with brow up and brow normal position in Group B, which is statistically significant. 6 cases of Group A was grossly undercorrected and planned for revision surgery, and in one case of Group B underwent readjustment of the sling due to overcorrection leading to exposure keratopathy, and in one case of Group B there was sling infection and removal of the sling, and the patient was planned for revision surgery. Now in discussion, we can see that the severe ptosis with poor function of LPS is mostly seen in unilateral cases, and in these cases we did not interfere with the other healthy eyes and tried to maintain the symmetry by adjusting the affected eye's lid height in both the groups. In ptotic eyelid, the LPS muscle is unable to relax, so that there is upper eyelid retraction in down gaze. In the plication, if the procedure is failed, the lid comes back to the previous state of lid height. Never the complete ptosis, which is possible in LPS resection. In sling surgery, if the undercorrection or overcorrection occurs as a complication, then the readjustment of the sling can be done at the apex of the pentagon. In respect to the uplift of the lid post-operatively, between the Group A and Group B, there was a good uplift between the uplift with brow up and brow normal position in Group B, which is statistically significant. So in conclusion, we can see that in severe ptosis with poor function of LPS, the tarsofrontalis sling with silicone rod is superior to LPS plication with 1 year follow-up, because post-operatively it is maintaining very good cosmetic lid height with good elastic property during blinking action. As the tarsofrontalis sling procedure is a minimally invasive surgery, so the early rehabilitation could be possible, and overall the post-operative complication is also minimal. This procedure does not require too much anatomical dissection, and it is an easy to perform surgical procedure. Thank you.
First of all, I would like to say that your presentation was very crowded. You could have put less points in a slide and made it readable for us. Okay, so font size was small, and you should have depicted it more through charts and pictures. That would have been easy to decipher. Okay, so my question is levator plication usually done in congenital ptosis?
Mainly, ma'am, sling surgery is mainly done. Plication is also done, but mainly sling surgery.
No, so I just wanted to know the rationale of the study. Okay. There are some aims for which you take up a study, so that's my question. What's the rationale of the study?
And both the surgeries are done. More common is sling surgery. Okay. More common is sling surgery. Mostly sling surgery is done.
Actually, she rightly said, see the outcome of ptosis depends a lot on the etiology of ptosis. It's because of congenital or acquired, inacquired, what is the etiology, underlying problem, neurogenic and all that. So it was like a mix of thing in your study where you compared two, techniques. And plication mostly is done when there is some LPS action. The indication of both the surgery as such, if you see, indications are different. So like there is some basic problem with the study design also, like when you are comparing two, techniques, at least the etiology, underlying etiology, maybe in the congenital cases or required, some uniformity has to be there. All right, and yes, plication routinely we do in congenital ptosis patients in our setup where the LPS action is, fair to good. Patients coming with mild, moderate, especially moderate, mild we do MMCRs, in congenital I'm talking about. And in moderate, ptosis where there is fair to good LPS action, we do application as a routine procedure. And then silicone sling, we know that it is done in patients with severe ptosis and poor LPS action, and generally not a choice for epineuritic or say, neurogenic maybe, but not for epineuritic. So like it was a bit confusing, study design.
So my question was basically because it's routinely done in mild to moderate cases of ptosis, and you have taken up in severe cases. So there must have been some rationale because of which you took up this study. That's what I was asking. I would now